Assalamualaikum and good morning, everyone. Thank you for being here today for the breakfast session today. Before we start the session today, I would like to make a few housekeeping announcements. Please turn off your video and set your audio on mute during the session. If you have any questions, you can either type it in the chat box or raise your hand to ask your questions. Okay. So first, I will introduce our speaker for today. Professor Dr. Jennifer Geraldine Dawes is a dental public health consultant at the Department of Community Oral Health and Clinical Prevention, Faculty of Dentistry, University of Malaya. She obtained her Bachelor of Dental Surgery from University of Malaya in 1987. Following that, she obtained her Master's in Community Dentistry with distinction from University of Malaya and subsequently was awarded the prestigious Datuk Dr. Sulaiman Golden Jubilee Scholarship Award from the University of Otago, New Zealand, to pursue her PhD studies there. Prof. Jennifer currently heads the Oral Cancer Research and Coordinating Center, OCRCC, located at the Faculty of Dentistry, University of Malaya. Her primary research interest is on psychosocial and social-behavioral aspects of oral cancer, namely patient and family-centeredness in the management of oral cancer. This includes assessing health-related quality of life among oral cancer patients and their caregivers across the trajectory of treatment and in survivorship phase. In terms of doctor-patient communication, her research involves the use of the Patient Concerns Inventory, PCI, and communication on breaking bad news of oral cancer diagnosis. As a testament of her expertise in this area, she has been invited as an international research collaborator for the QOL and PCI Head and Neck Cancer Group in Liverpool, UK. Apart from being an avid researcher, she is also a strong advocate for improving the quality of life of oral cancer patients and educating the Malaysian public on oral cancer. At national level, she is the organizing chairperson of the annual National Mouth Cancer Awareness Week program and serves as the co-chairperson for the National Oral Cancer Initiatives in Malaysia. In 2017, Prof. Jennifer initiated the formation and implementation of the Oral Cancer Patient Support Care Program at the Faculty of Dentistry, which was officially launched by Universiti Malaya's Pro-Chancellor Yang Berhormat Tuan Datuk Seri Dr. Aisyah Ong. This support care group is currently the only support care group addressing the psychosocial well-being of oral cancer survivors and patients, along with their caregivers in Malaysia. Okay, without further ado, I would call upon Prof. Jennifer to start her presentation for today.
Good morning, everyone. I'll just share my slides now. This morning, I will be talking a little bit about oral cancer in Malaysia and with some focus on social behavioral practices of the Malaysian population, as well as perhaps showcasing one evidence-based intervention for a high-risk community in Malaysia. So in terms of social behavioral practices, we'll look at the practice of oral cancer risk habits of different ethnic groups in Malaysia, as well as the health-seeking behavior of the Malaysian population who actually notice any abnormalities in their mouth. What do they do upon noticing this? Then we'll look at an evidence-based intervention to improve awareness related to oral cancer, to reduce risk habit practice, and to improve uptake of preventive behavior. Now, oral cancer is one of the cancers that are not very well known by many Malaysians, especially those in more rural areas. And as such, there is a great need to educate and to increase awareness about its associated risk habits. So let's look first at the practice of oral cancer-related risk habits. What do our studies reveal? Now, one study in 2019, which was a multi-center case control study based on the Malaysian Oral Cancer Database and Tissue Bank System, which is in OCRCC. And we did this study, and there were with about 790 cases and 450 controls. And so what did we find here, yeah, in terms of risk habits? Now, all these tables here just are summarized in this blue box. We found that betel quid chewing amongst all the other risk habits related to oral cancer confers the highest risk with an odds ratio of 6.49. So this simply means that somebody who chews betel quid is at 6 times a higher risk of developing oral cancer. And the synergistic effect of risk habits, when all risk habits are practiced, which are smoking, betel quid chewing, and consumption of alcohol, when they are practiced together, it confers a risk of 22 times greater, okay, a greater risk. And we also found that in terms of ethnic groups and their practices, Malays tend to smoke, Chinese tend to smoke and drink. Indians and indigenous people in Malaysia tend to do betel quid chewing. And looking at betel quid chewing, it is the biggest attributable factor, yeah, for oral cancer. And a 22.6 reduction of incidence can be expected if this habit is eliminated. So from here, you can already have an idea, yeah, of how important it is for us to tackle these habits, because they are preventable. Yeah, so increasing awareness is so important. Another study that was done between OCRCC and also with was a multi-country study with the University of Hawaii, and on about 1,000 Malaysians, yeah, residing in different communities in Peninsular Malaysia, Sabah and Sarawak. The aim of this study was to assess, yeah, betel quid chewing and the cessation habit among Malaysians. And what did we find? Now, we found we looked at why people start this habit in the first place. It was interesting to note that they do so because of family and friends influences. Okay, they like the taste, and it's very, very available. So it's a habit that is very sustainable. And looking at the mean age when betel quid chewing is commenced, it's actually at a young age, at 25 years old. And most of the sample here had a mean number of years of chewing of 27 or 28 years of chewing. Now that's quite a long number of years, yeah? And the mean frequency of chewing was about 6 times per day. And why do Malaysians who practice betel quid chewing continue to sustain this habit? Here you can see, yeah, these are some of the reasons. Because all friends chew, they like the taste, they like having something in the mouth. It's part of the culture, it relaxes them, it gives them energy. So you can see these reasons are quite deeply ingrained in their social behavioral practices, in their social culture, yeah? And the significance of chewing in social situations are also shown here. It is something they do during important family occasions such as weddings, anniversary, birthdays, when they hang out with friends. For, you know, in comparison, like here in Peninsula, when you want to hang out with your friends, you go to the mama restaurant, right, to have a teh tarik. But there, in some of these communities, especially in Sabah and Sarawak, among the indigenous, they actually hang out with their friends and chew betel quid. So looking at these reasons, why they initiate and why they sustain the habit, it just gives us an idea that this habit is very deeply ingrained in their whole social structure. Hence, the difficulty in, in trying to get them to quit the habit. Okay, now for those who, we also, in this study, we also explored reasons for quitting. Now, most of them quit mainly for health reasons, mostly when they have been perhaps diagnosed, with some sort of a medical condition, including oral cancer as well. And most of them had tried quitting less than 5 times. Some, at least 1/5, wished they had never started chewing, whereas 1/3 thought about quitting but were not ready. And about 1/5 did not consider quitting. So these kind of data emphasize that we have a lot of competing interests if we were to go and promote oral health or health among these communities. Now let's move from betel quid chewing to smokeless tobacco. Now here you see in this photo a typical female trader at one of the local markets in Kota Belud, Sabah. Now as you can see, she's got some of her smokeless tobacco stuffed into the buccal mucosa, and she is trading, doing her usual job. So in terms of this habit of using smokeless tobacco, females were 8 times more prevalent than males. It was very prevalent among older adults and the elderly. And interestingly, the mean age again that this habit was acquired was around 19 years, in their teenage years. This is surprising because sometimes we think it's only picked up at a later age, but not really. When you go and investigate, we find they actually pick it up at a very young age. And here on this side, on the right side of the screen, shown here are different grades of tobacco that are used, smokeless tobacco. So the darker the color, the more potent it is, and it packs a punch. So here I included some slides to give you an idea of how betel quid is prepared. Now this is a lady, a villager in Kota Belud, and we went to her house to see how she actually prepared betel quid. So some of the key ingredients would be areca nut, the betel leaf, gambir, which is a plant-based concoction, slaked lime, which actually originates from all these seashells and corals. And interestingly, these seashells and corals are grouped together at every village. In every corner of every village, you'll have this little area where seashells are grouped together and they are burnt and crushed to form the slaked lime. And then you have the beeswax. Now this beeswax is heated up to become a liquid form, to be applied around the lips so that the betel quid, when chewed, does not stain the mouth. Here too are photographs of some of the apparatus that are present in most of the houses. You have the areca nut cutter or cracker, you have a mortar, and you can see here their container of slaked lime, you have the betel leaf, and you have perhaps here probably the different types of tobacco, which is fermented. So everything is very readily available and accessible. Almost every household has this in Sabah. Example, in this time it was Kota Belud. And then you have this interesting way how people, the bajaus, they prepare their tobacco, how they ferment their tobacco. They get a piece of broken kuali here. They squeeze some lime juice on it. Excuse me. And they ferment the tobacco. the longer the tobacco is fermented, the more potent it becomes. And as you can see here again, this is different grades of tobacco. Okay, now, is this habit sustainable? Yes, very much so. In places like Sabah, where you have the morning market, all the ingredients needed for betel quid or even smokeless tobacco are very readily available and sold in the morning markets, which are called the tamus, yeah? So you can see here a trader with beeswax, all sorts of tobacco, lots of it here. And you have the gambir being sold here, the slaked lime sold in packets, yeah, as well as the tobacco, yeah. So it is a very sustainable habit. The morning market, when you go there to their local tamus, I think half or more than half of the tamu sells all these ingredients to sustain this habit. And then you have these long sheds present in the tamus, which sell nothing but tobacco, different types of tobacco, rokok down. And the people, as you can see, are so crowded, mostly men, and what they're doing is smoking. So is this a habit that is sustainable? Yes. Is it prevalent? Yes. And is it hard to, to address? Yes. Yeah. So when we do consider and think of interventions or promoting oral health, we have to consider their culture and their practices here, yeah, which are hard to break. Yeah. Now, looking at in one of our studies, we looked again specifically at betel quid practice in some of the indigenous communities, and we found that the habit, as I mentioned earlier, was first acquired in their teenage years, yeah? And females indulged more in this habit, right? In Sabah, we found that about more than half of the people, yeah, practice this habit, especially in Kota Belud. And the frequency of chewing per day was about 5 to 10 times of betel quid. And these were the ingredients that were present, yeah, and were added in, mostly tobacco, areca nut, betel leaf, slaked lime. Yeah. And of course, reasons for starting again the betel quid chewing habit, very similar to the other study. It was a cultural norm mainly. It was a form of socializing, and even they found that betel quid, some of the ingredients used in betel quid had medicinal purposes. Now, what was the knowledge and awareness, yeah, about the risks of practicing these habits? Shockingly, we found that at least about 3/4 of the people, yeah, in Sabah, among indigenous groups, were ignorant about the dangers of the habits that they were practicing. And also, a larger amount were unaware and unsure about what oral cancer was. And they didn't have a clue that betel quid chewing or smoking or alcohol consumption had any relatedness to oral cancer. And very surprising here to see that only less than 1/5 of them felt actually susceptible to oral cancer when they were practicing all these habits. Yeah. So you can see here, there is a great need to educate our people in certain parts of the country. Yeah. So from risk habits, let's move on to health-seeking behavior. Okay, what do Malaysians do? How do they behave upon noticing early signs of oral cancer and abnormal lesions in their mouth? And how do they interpret them? Yeah. So we undertook a qualitative study, 2018, to explore the pattern of health-seeking behavior among Malaysian patients with late stage oral cancer because we wanted to find out what were the factors that actually delayed them from presenting at the clinic, thus presenting with advanced stage disease. So we interviewed about 32 oral cancer patients throughout Peninsular Malaysia, Sabah and Sarawak. And what did we find? Yeah. Now, it was interesting because some of these findings were unexpected. We found generally when a Malaysian noticed something abnormal in their mouth, be it a non-healing ulcer or a growth, what did they do? They had 4 coping strategies. Okay. Firstly, they looked for home remedies. For example, some of them reached for the salt to use to rub salt on non-healing ulcers in their mouth. Then they also would go over to the pharmacies to self-medicate themselves, to buy certain types of medicines over the counters. For example, Bonjela. Okay, you have a non-healing ulcer, they go and get Bonjela and they do their own self-medication, especially when the ulcer is non-healing for more than 2 weeks. Some of them actually visited the traditional healers to get the medicines there. And finally, when these lesions didn't disappear or they became worse, the growth became bigger, maybe fungating or with pain, then what they did finally was they went to seek care from the health clinics. Now, but did they come to visit the dentist? No, they didn't. And that was, I think, quite shocking for us. They went straight to their general medical practitioners. Now, out of the 32 cancer patients we interviewed, I think only 2 went straight to the dentist. Why? Because they had had a history of oral cancer among their relatives. So they were aware of who to go and see. So they actually visited the dentist the first. Whereas the others, 30 over patients, went straight to their general medical practitioners. When we asked them why didn't you go to a dentist? They said, well, for them, the general practitioners were the ones who actually were in charge of their whole body, including their mouth. So this lack of awareness of visiting a dentist immediately was quite absent, yeah? And these are the main reasons why when these patients finally are referred to the dental clinic for these suspicious lesions in the mouth, it is quite late and they present with advanced stages. And that too, we found that some of the general practitioners themselves were not very familiar with some of the early signs and symptoms of oral cancer and treated it as a simple non-healing ulcer. So all these these findings told us that we also need to have training sessions for pharmacists as well as medical students to sensitize them to some of the early signs and symptoms of oral cancer. So in a nutshell, we found that Malaysian population, upon noticing something abnormal in their mouth and to try and make sense of their symptoms, they could use 2 pathways. They could use this blue pathway or the red pathway, pink pathway here. And it depended on whether they were feeling fearful, they had a certain amount of awareness or not. If they did not fear when they found anything abnormal in their mouth, and they had no awareness or knowledge of anything about oral cancer lesions, we found that there was a longer delay. But if they had some fear, okay, when they noticed these abnormal lesions, and with some level of knowledge and awareness, they then practiced these 4 coping strategies and finally ended up in the dental clinic, whereby when their diagnosis was confirmed, it was a bit too late in the sense they were at advanced stages. Okay, so from that, we will move on to an intervention. I would just like to share with you an evidence-based intervention that was carried out for a high-risk community in Sarawak. This was done in 2016. It was part of a PhD project, and it was a quasi-experimental study that was undertaken among the Bisaya community in Limbang. Yeah, and the main aim was to develop an intervention program, a structured education program for this community based on some of the health belief elements to improve their awareness, improve their health beliefs, as well as to promote practice of preventive behavior. And at baseline, we found that 3/4 of the respondents who lived in Limbang had heard about oral cancer. That was really good. However, their in-depth knowledge about risk factors, signs and symptoms, and prevention were lacking. So this was where we undertook the study in Limbang, which borders Brunei. And in this community, they practiced all 3 habits of betel quid chewing, alcohol consumption, as well as smoking. And as you can see in these photos here, these habits were so sustainable because you find people growing the betel plant in their homes, the compound of their homes, as well as areca nut trees growing along the roadside. And just to give you some cultural perspective of the Bisaya community, these are some of their festivals and their community events that they have, whereby they come together and they practice all these habits as well as betel quid. So just to explain a little bit about this oral health education intervention, it was designed and developed based on the health belief model elements, whereby you have perceived susceptibility, perceived seriousness, perceived benefits, perceived barriers, and perceived self-efficacy. So all these elements were put together to form a very structured oral health education module for this community. And the aim of it was to increase awareness and knowledge and to improve their health beliefs, as well as to seize and reduce their risk habits and to promote the practice of mouth self-examination. So pictorially, this is what it was. We had a control group as well as an intervention group. So in the control group, they were subjected to oral cancer talks in the conventional way that Ministry of Health would do, where they would group them in big groups in the balais, and they would administer the talk, and after which there would be a screening session. Now, in the intervention group, on the other hand, we tested this newly developed or health education intervention based on the health belief model. It comprised of various stations which were sequential in flow, and they were small groups. People were addressed in small groups. It was very interactive groups. As you can see here, they were different stations, and the purpose was first to give knowledge and then also to develop their skills in performing mouth self-examination, as well as to do a quick screening for them and to even give some advice on tobacco cessation and reinforce the information at the end using some posters. Now, did this education intervention impact the awareness and health beliefs and practices of this high-risk community? Well, let's look at the findings. In terms of awareness levels of risk factors and also about signs and symptoms of oral cancer, it was found that there was a significant improvement from baseline to first month. The intervention group, by the way, is the green and the control is in blue. So there was a significant improvement in their awareness at first month as well as third month within the intervention group, as well as between groups, yeah? Okay, and you see the similar pattern here as well, where there's not much of the control group was quite plateaued, whereas the intervention group showed a very significant improvement from baseline to first month and third month. Similarly, for awareness about oral cancer prevention as well as total oral cancer awareness, we found again in the intervention group, there was significant improvement, and then it plateaued here. And then on this side, there was significant improvement, and further in the third month. And you found that the differences between groups were significant. So in summary, for oral cancer awareness, there was a significant improvement, yeah? In the control group, there was some significant improvement in terms of awareness about risk factors and prevention. However, in the intervention group, this improvement was seen in terms of risk factors, signs and symptoms, and prevention. And the quantum of increase of oral cancer awareness at the first month and the third month was significantly higher in the intervention group. Now, what about reduction of risk habits? It was found that in the intervention group, we just looked at cigarettes smoked per day, the number of cigarettes. We found the mean number of cigarettes smoked per day from baseline in the intervention group significantly dropped to first month and then to third month within the group, as compared to the controls who actually practiced a bit more frequent cigarette smoking. And the final difference between these two groups at 3 months was also significant, yeah. So in summary, in terms of cessation and reduction of risk habit practice, in the intervention group, there was a significant decrease in mean number of cigarettes smoked per day. There was also a significant decrease in frequency of consuming alcohol and betel quid among those who were still practicing the habit. And of course, there were some respondents who self-reported that they actually quit smoking, drinking, and chewing betel quid from baseline to third month, but this was not very significant. Now, finally, what about the uptake of preventive behavior? As in mouth self-examination, we found that in the intervention group from baseline to 1 month and 3 months, there was a significantly higher number and percentage of respondents that performed MSC at the third month. And among those who did perform the MSC, approximately more than 2/3 of them performed it once a month, as was recommended in this intervention. And what was also interesting was that 85% of the respondents at third month strongly then believed that by performing MSC once a month, it would help them to detect oral cancer lesions early. And this was good to see that there was a slight change in their beliefs, their attitudes towards MSC. So as such, as an overview, was this oral health education intervention effective? Yes, it was for this high-risk community. And as you can see here, I would like to acknowledge the Sarawak Oral Health dental nurses and their teams for doing a very good job in actually conducting this intervention. You can see photographs here, how they taught the patients on how to use the mirror, face mirror, and how to conduct mouth self-examination. And we got the patients to try it out for themselves. Yeah. So with that, I think, in conclusion, I would just like to finish off by saying the practice of these risk habits and the social behavioral practices of Malaysian population makes it very challenging for oral health promotion to actually be successful. And I think at the end of the day, we have to come up with effective oral health promotion programs such as this, which is catered to each culture of the community, be it the indigenous community or other communities in Malaysia, to help them modify their behaviors that are risk-related, especially to oral cancer. So with that, I thank you. Yeah.
Thank you, Prof. Jennifer, for the insightful presentation. Prof, we have a few questions from the audience.
Yes,
Okay,
sure.
by anonymous attendee, he didn't put his name. Hi, doctor. Just wondering if there is any studies on the drinking frequency that increases risk of oral cancer.
I think there are definitely worldwide, and also in our country, mostly worldwide, there are. And if it's, I may not be able to recall on the spot any, but definitely there are studies done on alcohol consumption. And there is a risk related to drinking frequently, yeah? Heavy alcohol drinkers, and the risk of developing oral cancer.
Okay, next question by T. Sarah. Nice talk, thank you. May I ask which ingredient in betel quid is carcinogenic and which is addictive?
Okay, it's the ericolin that is present in the erica nut that is carcinogenic. And of course, with the addition of tobacco, okay, that also gives an addictive characteristic to it, as well as ericolin, taken together with tobacco does induce a addictive effect as well. So it's the erica nut. Okay.
Okay, next question. I was told by the Bangladeshi men working to collect rubbish, they also chew betel nut to keep them fresh and energized.
Yeah, I mean it's a habit that. Sorry, was there a question in that?
Yeah, I think that was just a comment. Yeah.
Right. Now, this is very prevalent, not just in Malaysia. It is especially so in South Asia, among the Indian continent, and among Pakistanis. They chew pan. Okay, pan is also a carcinogenic substance, and it just has different ingredients in it, and people chew it to get energy. And if you notice my slides earlier, one of the reasons why Malaysians chew betel quid is for energy. They feel energized. So it gives them that oomph. Yeah. So you're perfectly correct in saying that betel quid does energize people, as well as in different other countries, they chew other types of things like pan. Yeah. Yes.
Okay. What would the dentist do after discovering oral cancer? Would you refer to an oral surgeon or treat yourself?
Well, normally we train, we as best as we can, we try and train all dental officers throughout Malaysia to be able to identify early lesions, yeah, of oral cancer. And once they suspect a lesion looks a bit suspicious, then definitely the first thing they should do is immediately, yeah, without any delay, refer the patient to the hospital, the oral surgeons who are based in hospitals, so that they can further check on the patient and do a biopsy. It's only through a biopsy that you would confirm this diagnosis. Yeah.
Okay, next, good work. What is the incidence of oral cancer in those who chew, smoke, and drink?
I think it confers a high risk, right? Incidence-wise, perhaps maybe Dr. Maria, would you be able to comment on that?
Prof, perhaps we can show the slide that population attributable risk, just to show a picture. Yeah.
We'll show them again. Yeah, that slide. Let's see. All right. Yeah, you see this slide here. Oops, sorry, what happened? Give me a minute. Now, it poses a risk for sure. Yeah, as you can see, synergistic effect, yeah, meaning the practice of all three habits it confers a 22 times higher risk, okay, of developing oral cancer, as I showed in this first slide here. So you can see here, yeah. And that's why it is that by reducing betel quid chewing habit, you actually can reduce the incidence by 22.6%. Okay. Okay. Okay, next question.
Next question. Is there any biomarkers to check for oral cancer?
Yes, there are. Unfortunately, I'm not qualified to comment on those things. There are definitely biomarkers to track oral cancer, and this kind of research is undertaken by our my colleagues who do research in biomolecular aspects. Yes, there are biomarkers.
Next question. Implants and amalgam, can it cause oral cancer?
Implants and amalgam. Interesting. So far, I don't think any case has been documented. However, ill-fitting dentures causing chronic trauma has been implicated, especially, for example, in tongue cancer, where there is continuous number of traumatic incidences in the oral cavity. But in terms of implants and amalgam, not that I know of. Yeah.
Okay, last question, Prof. Normal people often say eating hot food without blowing them can cause oral cancer. Is that true?
I wouldn't want to speculate on that. Those are just, I think, speculation, but we don't have hard evidence for that. Yeah. However, in terms of nutrition and the type of food we take in, yeah, there is some evidence about salted fish. Too much a diet high in salted fish and very frequent intake of salted fish has been indicated as one potential risk for oral cancer.
Okay, that's all the questions we have today, Prof. But actually someone raised their hand. No, he's gone now. Just now someone raised their hand. So I think that's all we have, the questions for today. Thank you, Prof, for the talk today, and thank you everyone for attending the session today. With that, I end this session. Thank you.
Thank you very much, everyone. Bye.